Hello, and welcome to OvaryActive. I'm Dr. Rebecca Dunsmoor-Su.
And I'm Dr. Amy Voedisch, and we are your expert guides on the strange and often uncomfortable journey that is perimenopause. Hi, everyone. Welcome back to OvaryActive. I'm Dr. Amy Voedisch.
And I'm Dr. Rebecca Dunsmoor-Su. And this week, we are going to talk about lab testing. This is a big thing that comes up in many an appointment, on questions, on our Instagram. It's just a constant refrain from our patients.
Yeah.
Many patients will come in with a huge list of labs that they want checked that they got from, TikTok or, some influencer or ChatGPT. And I believe that happened to you this week, right, Amy?
Just this week, someone had a long list of what ChatGPT told her, and I was like, oh, here's AI. Yay.
Yay. I love AI.
Yeah.
I also get it from a lot of people who have seen other practitioners who maybe have a different way of practicing and they want to get all these labs done, but they don't want to order them because they maybe aren't practitioners who actually have that medical licensing. We thought, let's talk about labs, lab testing, and when it's indicated, and why sometimes when you come to a provider like Amy or myself, we're going to say no.
Yep. Which is hard. And I talk a lot about practice styles and sort of different practice styles, and just sort of it's great to kind of set those expectations, I think, so everybody's on the same page, rather than not having that direct conversation and then having patients feel like you're shortchanging them because they don't really potentially understand the indications of when to test and when not to test and the usefulness of testing and all those kinds of good things. So
I totally agree. One of the things that I'm really lucky about is that I get 30 minutes with all of my patients. So when this comes up, I generally have the time to explain why I'm not thinking those things are indicated. But I think you make a really good point about practice styles. And, for those of us who have been listening for a while, you'll know that Amy and I both practice in line with guidelines from the Menopause Society here in North America.
Yep.
With the Global Menopause Society. And really, we try to provide our patients with what we call evidence-based care.
Yes. So, we want to make sure that you're getting all the care that you need. You're having everything done the way it should be, but you're also not being taken advantage of.
Right.
And that's one of the things that can happen is sometimes when there's like practices that do a lot of lab testing sort of over and over and over again, a lot of times you're paying out of pocket for that. And there's a reason you're paying out of pocket for that because they're really not indicated. And so it's important to just kind of think about, okay, what's helpful? Like what's going to be super helpful during this time? And what are things that maybe I can let go of and not worry so much about?
Yeah.
Yeah.
And I think the other thing to talk about when we talk about labs is, you and I tend to think of blood labs.
Right.
But there are folks who sell urine testing, whether it's dried or fresh. There are folks who sell saliva testing. And we're going to talk about that and what we think is valid, what we don't, and why we think that way. And, spoiler, if you have to pay out of pocket cash for something, probably not a validated test.
So let's start with what to check.
Okay.
Patients will come in and they will go through this list. I'm going to go through the ChatGPT list I got this week. So the ChatGPT list this week was estrogen, and they'll ask to check for, as I think we've said before in this podcast, there's 4 different types of estrogen. They'll ask to check type 1, type 2, and type 3, which is estrone, estradiol, and estriol. They want to check their progesterone level. They'll ask to check your FSH or follicle stimulating hormone, your luteinizing hormone, your thyroid, but it's not just the thyroid. Sometimes they're requesting like, I want to have my free T4, my free T3, my reverse T3, my indirect, my direct, like all these different very complicated thyroid tests. Cortisol, that's a big one, right?
Oh yeah, we'll talk about that.
Yep. And then DHEA and DHEAS. So those are, and we'll explain what those
and
acronyms
testosterone.
are.
Don't forget testosterone.
Oh, how did I forget testosterone?
I don't know.
What? Well, ChatGPT didn't bust out testosterone, so.
Well, there you go. See, ChatGPT, not so useful.
Not so useful. Although people use it all the time. And in full disclosure, my husband is an expert in the legal aspects of AI, and it's a big part of his career. So we can't bash all AI. I don't think the medical part has quite caught up
Right.
yet to some of the other things.
So that was a pretty long list you just gave us.
Yeah, it's a super long list, right? So the question is, should we check them? Should we not? So let's go through them, see what we think. Let's start with the ones that are most related to our menstrual cycle. So sort
Perfect.
of our female hormones.
So I'm going to start in on estrogen.
Okay, great.
So estrogen, as we know, considered the female hormone, although men make estrogen too. So a lot of people think that they need to know what their estrogen level is.
Mm-hmm.
And I tell people that your estrogen level is really what you're talking about is your estradiol level.
Right. That's
So
E2.
E2. E1 is a precursor. It's not very active in our body. Checking that doesn't tell us a whole lot. E3 is made by the human placenta. So I'm not going to check that unless you would be pregnant. But even then, I'm not going to check it because
Right.
it doesn't matter what the E3 level is.
So if you don't have a placenta,
Right. You don't have any.
you don't have any. So it doesn't really help to check it.
Not going to check it. But E2 or estradiol is the active hormone in our bodies. It's the one that binds most strongly to the receptors. It does sort of all the things that we think of estrogen doing. But estradiol changes during the menstrual cycle. So it builds over the course of the first part of the cycle, then it plateaus, then it goes down. So there's not one level we're looking for. The actual normal range of estrogen in women is very broad. I think in the lab I use, it's between 12 and 500.
Right. Huge.
A huge broad range because all of those values might be right at some point in a cycle.
Right. Really depends on where you're at in the cycle.
Right.
Mm-hmm.
Say you're postmenopausal. I can tell you, your estrogen's very low.
No need to check it.
No need to check. Unless you are taking supplemental estrogen, it's low.
It's low.
I don't need a number to tell me that,
Yep.
especially if you're symptomatic. If you're in perimenopause, that damn estradiol's all over the place.
Right.
Not going to help me because, one of the things I often say to my patients, and I think it's a really critical point to make, is I don't care what your absolute level is today. You are here in my office symptomatic. So if I send an estrogen level and it's normal, do you want me to tell you you're all fine, it's all in your head, go home? No, of course not. You're symptomatic. And therefore, I need to find a way to treat you, regardless of what that estradiol level is on this day, because that'll be different tomorrow.
Right. So take home message when you're coming in and you're in menopause, not on hormone replacement therapy. And because I've had this happen, people will be 58, 60 years old, haven't had a period for 5 years. I'd like to get my hormones checked. I'm like, we don't need to check them because we already know what they're going to be.
Yeah.
And so they get a little fussy, but I'm like, I guarantee you it's going to be low because that's what your ovaries are doing right now. You're not getting it from any other source. So no reason to check it there.
Yeah.
But there are times when checking an estrogen level might make sense. So I'll think about it. If I have a question of whether or not someone's symptoms might be related to this or not, and I'm trying to get a full picture of what's going on.
That's a great time to check it.
Might be like somebody who's younger where you're like, you wouldn't really be thinking of perimenopause and menopause, but you're like, well, let me just make sure we're not like in premature menopause.
Right.
Or we have some sort of premature ovarian.
And I always qualify with those patients. One spot check may not give us that answer. We might have to do it at multiple intervals because, as we said before, this changes all the time.
Right.
So we may need to get a pattern in order to sort of get an idea of what's going on.
Yeah, for sure. If you've had a hysterectomy, so your uterus has been removed, that means we're not getting your period as a signal for what's happening with your ovaries and your estrogen levels. So sometimes I'll check there if we're, again, sort of questioning what's happening. We want to know what's going on.
Again, might need to do it multiple times.
Right.
Get a pattern, especially in perimenopause.
Think about what we're doing. And then you and I will both periodically check if someone's on hormone replacement therapy or menopausal hormone therapy because we need to get some more information about what's going on with their medication and whether they're absorbing or,
Right.
What's happening. So
I would say that's probably the most common time I'm checking it. It's because someone's been on transdermal estrogen through a patch or a gel or whatever, and we've sort of dialed up to the highest dose we usually use, and they don't seem to be getting relief.
Mhm.
And that's when I'll check to make sure that they're someone who absorbs well through their skin.
Yeah, which is really interesting. I actually had someone the other day who is on oral estrogen and the level was super low on a very significant dose. And then we switched her over to transdermal and now she's fine.
Yeah.
Like it's actually absorbing. So you're like, that's the opposite of what I would think this would do. But that's one of the reasons why we'll check it if you're actually on hormones. And we're not looking for a particular target level for you to be at necessarily, because again, like we said, the normal range is anywhere between
12 and 500.
yeah,
Yeah. 20 and 500, whatever it is.
whatever
Yeah.
your lab is. I mean, it's huge. And so there isn't one number where we're like, you're going to feel better at 50.
I might feel better at 50, and you, Amy, might need 75. And another person might feel great at 20.
And I'm very high maintenance. I think I'm going to
Yeah.
be more like a 150.
Yeah, possibly.
Possibly.
Possibly. But everybody's different. So we don't have a range of estrogens at which your symptoms go away.
Right.
And that's another important point. I can't tell you from that level that I would do that you should feel better.
Right.
What I need to ask you is, do you feel better?
Your body will
Yeah.
tell you, is this enough for you or not?
Right, right. Every once in a while I've checked in someone who comes in with therapy that I wouldn't normally prescribe, whether that be a compound or a pellet or something like that, just to make sure how high they've gotten, because I've seen some very, very high levels.
Yep.
And sometimes that might inform how I'm countering that with progesterone if I'm really worried about precancer or cancer of the uterus from those very high levels.
Yep.
You know, the other main female hormone that we talk about is progesterone.
Oh, yes.
So tell me when you would test a progesterone.
Oh, I've had some I would say very frustrated patients with me because they really feel that they need their progesterone level checked.
Right.
So progesterone, again, kind of like estrogen during a normal menstrual cycle, has a particular time where it peaks and then a time where it goes down. And it basically peaks after you've ovulated, usually about 7 days-ish after you've ovulated. So we really only check progesterone levels if we want to know if you're ovulating.
Yeah.
And typically in the setting of someone who's having fertility issues, trying to get pregnant, and we're trying to see if they're actually ovulating to help them figure out why they're not getting pregnant. But that's really kind of the only time where checking a progesterone level is helpful. Because other than that, it's usually pretty low. And it
Yeah.
doesn't really play like a big role in like diagnosing perimenopause or diagnosing menopause. And we also don't need to check progesterone as part of menopausal hormone therapy.
No.
And the reason is because we have 1,917,000 billion articles looking at the proper progesterone dosing to counterbalance estrogen, right? We've talked about how estrogen stimulates the lining of the uterus to grow. You need a progesterone to counterbalance. We know what the standard doses are. So we
Right.
don't need to be checking levels because we have studied this ad nauseum. So we don't need to check your progesterone as part of your menopausal hormone therapy.
Yeah, the one place where I see this being done is in people who are prescribing a lot of compounded medications.
Yeah.
So they're compounding estrogen, they're compounding progesterone, and they're checking. But I don't know that they're actually adjusting based on those levels. I think they're still actually adjusting primarily based on symptoms. You know, I can understand them checking progesterone in that situation because when you compound progesterone, it actually does not work very well. It doesn't absorb. So progesterone is a very big molecule.
Yep.
The progesterone you get from the pharmacy, the FDA-regulated form, is micronized, which means it's sort of suspended in an oil base that sort of protects it and gets it through the stomach and gets it to absorb. If you take it out of that format, it does not absorb as well. And we know it does not absorb topically. They tried, trust me. Every pharmaceutical company who makes progesterone wanted there to be a topical progesterone because then they could put it in the patch and it'd be bioidentical. They tried.
It does not happen.
It did not work. There's a reason there is no FDA-approved topical natural progesterone.
It's not happening. There are topical progestins, which are different molecules work at the progesterone receptor. But when we're talking about hormone lab checking,
natural progesterone.
Natural progesterone does not get absorbed through the skin.
No, it does not. It does, however, absorb through the vagina.
That's a fun fact. Everything gets absorbed through the vagina.
The vagina is very good at that.
It is.
However, and I've had this asked, there aren't any currently, I'm going to say currently for reasons I cannot disclose. There are currently no FDA-regulated hormone therapy vaginal progesterones. There is a gel used for fertility that's used to sort of support fertility in recurrent miscarriage or in IVF cycles. But that is not necessarily the right dose for hormone therapy. So just subbing it in doesn't necessarily work. We haven't trialed it for that. Number two, it's in an alcohol-based gel, so it's really not something you want to be putting in a postmenopausal vagina chronically.
That sounds fun.
Yeah. Yeah. I mean, it's fine for a couple of days, but like not for prolonged use, especially not in a postmenopausal vagina. I've had a lot of patients who wanted to try that and were put on it by somebody else and had a lot of irritation.
Ooh.
It's not the most comfortable stuff. And it's also really, really expensive because it's a fertility medication.
Yeah, pricey.
And the oral FDA approved natural progesterone is pretty damn cheap.
Yeah, it
There's
really is.
7 billion generics.
So there's no reason to pay for that.
No. I do know that there are vaginal methods of delivering progesterone for menopausal hormone therapy that are under development. And I'm hoping that in a couple of years, we'll have even more options of great FDA regulated medications for women to use.
I know it would be awesome, right? It'd be
Hmm.
amazing. Okay, back to lab testing because you and I could go on
Yes.
and on. We get
Sorry.
sorry, we get some brain fog,
Tangent.
get some brain fog and a little ADHD going, and next thing you know, we're going to be talking about unicorns and butterflies.
Yes,
Okay,
probably.
I mean, that's all we can do. Okay, let's talk about FSH. Tell us
Ah,
about that one.
yes. One of my favorites. So, FSH, follicle stimulating hormone. It is made in your brain. It is the hormone that signals to your ovary to develop a follicle and therefore an egg, and then bring it out to ovulation. And we'll talk about LH, which is the other half of that equation, next. Follicle stimulating hormone is generally low when estrogen is high. So, estrogen provides what we call negative feedback on it. So it gets higher and higher and higher as we go through the menopausal transition because your brain is saying to your ovary, wait, I'm not seeing my feedback loop. I'm not seeing where's the egg? Where's the follicle? Why am I not getting the correct feedback? It's not quite that simple. There are other hormones that communicate between the ovary and the brain, and some has to do with inhibin B, which no, we cannot test. But, in general, that's why we check FSH, because if your FSH is very high, it's telling us that your ovary is not properly responding to your brain, which is telling your ovary to respond, and therefore you're probably in that menopausal transition. And once you go through menopause and the ovary really stops making estrogen, the FSH goes up and stays up. In the perimenopause, it goes up, it goes down, it goes somewhere in the middle, then the next month it's down, and then it's up again. There's no predictability about it. So really, it's not a test that can tell us when you'll transition through menopause. It's not a test that can even tell us if you're in perimenopause because some proportion of the months it's going to look totally normal. If someone's had a hysterectomy and we're trying to determine and we do an FSH and it's normal, I'm going to check again in 4 to 6 weeks and see if it's still normal. And then I'm going to check again in 4 to 6 weeks and see if it's still normal because then I might get a hint of what it's actually doing.
Yeah, where it's going, what's happening.
Yeah.
So you mentioned LH or luteinizing hormone. This is not a hormone that really, again, plays like a super big role in perimenopause or menopause.
Mm-mm.
Luteinizing hormone, also a hormone that comes from the brain. It's part of our whole complicated menstrual cycle, but it's the hormone that basically triggers ovulation. There's sort of a spike and a down, and it says, okay, go time.
Go time.
Go to the ovary to release the egg. So this is what is being checked in the urine for those ovulation predictor kits, that if you're trying to get pregnant, you can buy them over the counter. They do a urine test. They check to see if the luteinizing hormone's in your urine, because if it is, that's saying like, okay, the levels have gotten high enough that the spike has happened to trigger ovulation.
Right.
So you really don't need to check it as part of perimenopause and menopause. It just doesn't really play a role in what's happening here. It doesn't help us diagnose anything that's happening. Sometimes you can look at the ratio of LH to FSH to help with like the diagnosis of polycystic ovarian syndrome. So it's not that it has no value for serum testing in different scenarios, but it really just doesn't play a big role. And we really don't check it all that much, even in kind of these other settings either. But
Right.
it's an important hormone. So it has value in the body, but it doesn't necessarily have value as part of lab testing and wouldn't change how we approach perimenopause or how we'd approach menopause and how we treat you.
And it's also only really around in a normal menstrual cycle for a couple of days.
Yeah, it's like a
It's a spike. If you're not in that perfect window to see the spike, you're not going to see it. But also if you do get a high value, you're probably in that spike. It's not helping us in any way to understand what's going on. All right. Now we have to address those hormones we like less. The ones we don't deal with every day,
the
Amy.
ones that don't involve your vagina. Let's
Right.
talk about those.
Or your brain.
Or your brain. I like the brain. I like the vagina. I like
Uh-huh.
the ovaries.
Yeah. The thyroid is less fun for me.
Okay, so your thyroid, for those of you on YouTube, it's right kind of in here.
It's in your neck, for those of you not on YouTube. So your thyroid is a very important gland that provides us with thyroid hormone. And thyroid hormone has a ton of functions in the body. It's one of our main sort of metabolic regulators. It regulates how we metabolize calorie. It regulates, how a lot of our different systems operate, including like how fast our heart beats and, our blood pressure. Like all these things are directly influenced by thyroid hormone. It's very important. If you have no thyroid hormone, you do not survive. So
Right.
let's be
Yes.
quite clear. It is a hormone important for life. A lot of people know about thyroid because a lot of the signs and symptoms of thyroid deficiency look a lot like menopause.
Mm-hmm.
Now, thyroid deficiency people tend to be more cold, but sometimes they can be hot. They tend to gain weight. They tend to feel tired and sluggish. So a lot of these show up also in that menopausal transition. So sometimes we might be checking thyroid if, maybe we're not so sure someone's transitioning in perimenopause or that hasn't been checked in a long time and we're just a little worried we might be missing something. We might send a thyroid test at that time just to make sure nothing really bad is going on.
Yeah.
And there is a decent amount of thyroid disease, especially in
Yeah.
women.
It's very common.
There's autoimmune thyroiditis, which happens in a lot of women and definitely worth checking. And that can come with sort of a spike of thyroid hormone at the beginning. So people feel very hot and their heart races and they're up all the time and they feel kind of manic. And then the thyroid stops working and they get all this sort of cold intolerance and feeling sluggish and more depressed.
And I'll also check it. I mean, one of the other things too is when people are having hair loss and like weird skin changes, right?
It can have those signs too, or fingernail changes, all these things that we also associate with menopause.
I know. Where you're like, ah.
Yeah. So definitely there are reasons to check thyroid. You don't need to check it all that frequently. Like typically would do it annually at most, unless you're on replacement and we're trying to get it right. You mentioned at the beginning, there are lots of thyroid tests that you can order.
Yep.
So the thyroid tests that tell us how your thyroid is functioning are your thyroid stimulating hormone, another brain chemical that tells your thyroid to make thyroid hormone.
So we like that one.
We like that one. That tends to be the one we check first, because if that's normal, then we know that the feedback loop is working and that part of your brain is seeing enough thyroid hormone to be in the normal range.
Yep, exactly. Just like with FSH and estradiol, it's like a whole negative feedback loop. So if your thyroid is producing T3 and T4,
Right.
and your brain is seeing it, then your thyroid stimulating level won't be elevated or suppressed if it's seeing too much or too little.
Right, exactly. And, if that TSH is right in the normal range, we really don't need to test beyond that.
Right.
The other hormones, the T4, the T3, some of these, reverse and other tests.
Inverse,
really,
reverse, on top of your head. I don't know.
On top of your head, thyroid antibodies. Those are all more complex endocrine tests to sort of get at what's actually going on with the thyroid that's not functioning well. So really, I think a lot of people think that you need a more complex test. Really, the TSH tells us pretty much all the information we need about your thyroid and how it's functioning at this time. Doesn't mean it can't change over time, and certainly thyroid testing may occur at certain intervals throughout your life. But, we can be pretty reliant on that TSH test.
Yeah. So that's a good test to do. And
Mm-hmm.
it's hard. If you have thyroid issues and you're going through perimenopause, they just sort of compound each other.
Yeah.
So it is an important one. If it hasn't been checked, I'll usually throw it in there just to be like, if they're having symptoms that seem like it could be thyroid, just because you're like, man, we want to make sure that we're treating all the
We
things.
treat that if we need it.
Yeah.
And thyroid hormone can be an amazing treatment that can solve a lot of problems. I do want to throw in just a quick PSA warning, because I've seen more and more people being put on thyroid hormone when they are not having thyroid deficiency, because it makes them what we call hyperthyroid. It makes them slightly too much thyroid, which increases their metabolic rate. So I've seen people doing it to help with weight loss. The problem is it does many other things as well.
Yeah.
It puts stress on your heart.
It stresses your bones.
It stresses your bones. You take more calcium out of your bones. It especially worries me when perimenopausal women are being put on this because they're already losing bone.
Yeah, I agree.
And we're not going to rebuild it.
Nope.
At the end of this. So it's just something to think about. It may sound like an easy fix for weight gain, but it's not. It has a lot of downstream consequence. It's not a totally safe therapy.
We get how stressful weight gain can be, but what's more stressful is having a hip fracture or a bone fracture. I mean, these are things that really can impact your mortality.
There are lots of therapies that we can use to help with manage weight that aren't thyroid hormone and have a better safety profile,
Yep,
actually.
exactly. It's just really not a safe way to do it.
Yeah. And then the last thing I was going to mention about thyroid is that if someone is hypothyroid and taking thyroid hormone, if we add female hormones, they do interact a little bit. I have never really seen any problem with the transdermal estrogens and thyroid hormone. It doesn't seem to alter the level, but there's some concern if you're taking an oral estrogen that it could alter the level of the thyroid hormone that's absorbed. So it's just good to get like a check about 3 months in.
Yeah, making sure they're not interacting. And that's actually for your thyroid, if you're on thyroid replacement, that's actually kind of a general PSA for almost anything you start to take can impact your absorption with it.
Right.
But estrogen's one of those things. So something to think about.
Yeah. Can you address cortisol,
Do I
my
have
friend?
to?
You do.
Okay. All right. Talking about cortisol. Cortisol is a big one. I mean, I get asked about cortisol every day, multiple times a day. It's probably one of the biggest ones that are talked about on social media, and people will talk a lot about that. Well, my cortisol level's up. I'm super stressed. I can't lose weight. It's impacting my sleep. It's all because of my cortisol. I need to check my cortisol level.
I've also seen it talked about in some arenas as adrenal fatigue, like you're tiring out your adrenal glands from making so much cortisol.
Yes.
And I do like to tell my patients adrenal fatigue is not a medical diagnosis. If your adrenals are truly fatigued and no longer making cortisol, that's a disease. That's Addison's disease, correct? Yes. Sorry, I get my Addison's and my Cushing's mixed up sometimes.
I don't really like the adrenal glands. So
I know, I don't either. But that's a very serious disease with very significant symptoms. Being stressed means that you're making more cortisol, absolutely. But that's the correct response to stress. Your body is doing what it's supposed to.
So, okay, what are these adrenal glands? So adrenal glands are these little tiny like hats that sit on top of your kidneys. They're like little bloops.
They're like kidney ski caps.
Little kidney ski caps. They look like little dumplings. So they sit on top of your kidneys and they make a ton of hormones. I'm talking like per real estate square footage capita of these are like serious powerhouses.
These are powerhouses.
These are powerhouses. So they make a lot of things. And one of the hormones that they make is cortisol.
Right.
And so cortisol is our stress hormone, like we said. So it helps us to respond to stressors, physical stressors, emotional stressors, mental stressors, just stress. So like inflammation and maintaining blood sugar levels and regulating metabolism. And our cortisol levels fluctuate naturally throughout the day. So we have slightly higher levels in the morning. We have lower levels as the day progresses. It's kind of, they
go to their lowest point in the middle of the night.
Yeah, middle of the night. And then they start to kind of come back up. So they fluctuate. And so when we're stressed or under stress or whatever, those levels can become more elevated and there can be bigger swings and fluctuations, but these aren't dangerous elevations. You're not causing a disease of the adrenal glands because you're stressed out at your job.
Right. But more importantly, if we check a cortisol level and it's on the higher side, yes, we know you're stressed, but we knew that already from talking to you.
Yeah. Most of the time when I check it, I have to say, despite how stressed people are, in my particular practice, I don't know if it's my lab or whatever, I don't really see it being elevated
you don't see
that
it
often.
High. No.
But it certainly can be, right? But when you live in a state of stress, you're exhausted, you're not sleeping well, you're stressed about losing weight, you're over-exercising, you're under-exercising, all of these things can absolutely come into play. So really what you need to do, if we know that these stressors are there, is to work on stress reduction.
Right.
So rather than checking your level, which most likely will probably be normal, but even if it is a little bit elevated, we're going to tell you to do the exact same thing.
Right. Because there's no medication that makes your cortisol go down.
No, there's no medication. There's no supplement. There's nothing that you can take to make your cortisol level goes down. So the only way to get your cortisol level down
is solving the stress. But that's hard, Amy.
It is hard.
It is hard. I don't want to make light of that. The two of us are probably your worst examples for how to solve your stress issues. Neither of us is good at it.
I don't know what you're talking about.
We have some insight into that. What I tell my patients is you are having symptoms from a life that is out of control or feels out of control to you. The only way to solve that is really to deal with that lack of control, deal with that stress, deal with the issues that are causing that. I don't have a pill for this.
No, I wish.
Hmm.
That would be awesome.
I know you and I probably both take it.
I know I would probably overdose on it, but we
Yeah,
just don't have a pill for it. And so that's another reason why it's not super helpful to check a cortisol level.
right. Are there pathologic diseases of the adrenal gland? Yes, there are. There's Addison's disease when they stop working. There's Cushing's disease when they're overworking. Those are pretty dramatic disorders.
Right. You will not miss.
You're not going to miss those.
No. They present themselves and you're like, wow, something is really seriously wrong with me.
Right.
So it's not subtle and they're not, and those symptoms are not perimenopausal symptoms.
No, no,
So it doesn't get confused with perimenopause.
no,
So
not
again,
really.
that's why it's not super helpful.
Right. You took the hit for dealing with cortisol, but you gave me DHEA and DHEAS, which means I have to say the word,
Sorry.
which is cruel because it's a really hard word to say. So, DHEA, or dihydroepiandrosterone.
Nice.
I got through it.
Done.
And that same word, sulfate, is
Yes.
DHES. Sorry, some of these chemical names are really hard. There's a lot of syllables. They are also made in the adrenal gland, and they are precursor hormones. So this is a precursor that circulates in our body and can be made into lots of hormones, but most commonly made into estrogen and testosterone. So some people believe in checking it to see if like there's a precursor deficiency that could lead to an estrogen and testosterone deficiency. But that's not really shown in science. That's not really how it works. And DHEA is not telling us anything because if you don't have enough estrogen and you have DHEA, you're going to convert it into estrogen. If you don't have enough testosterone, you have DHEA, you're going to convert it into testosterone. And if you're using up a lot of DHEA, you're going to make more. Sometimes we see it as an elevated level. And we tend to see that in people who are on the polycystic ovarian syndrome pathway or of that type. And what it can lead to is like excess body and facial hair, deeper voice. Sometimes your menses get irregular, some acne. Some of this may sound familiar from perimenopause. I think we've explained this before. When your DHEA and testosterone tend to be higher in these patients or androgenic type hormones, which means you see more, like we say, androgenic or male type phenotype on the outside. We get that also in perimenopause as your sex hormone binding globulins going up and down. And sometimes when it's down, you read more of the testosterone you're making. So DHEA is a precursor. It's not something we need to check. Really, if we're checking hormones, it's going to be more in the estrogen, testosterone, and we might have specific reasons for doing that. But checking the DHEA, we only really do it occasionally to prove that hyperandrogenism in PCOS.
That's really the setting. PCOS, sometimes people will check it when there's like a lot of hair loss in women and you're trying to
Right.
figure out why.
Right. Are they hyperandrogen?
Are they hyperandrogen?
There are rare tumors of the ovary that can really bump this hormone and testosterone, but they are rare. So if we're checking for those, we might do a DHEA and testosterone together.
To kind of see what's happening. Yeah.
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 And then we should talk about checking testosterone because there's some complexity in checking that. Isn't there, Amy?
This comes up a lot. People want us to check this all the time. And I think we've talked about this in prior episodes. So I don't need to like beat it over that. But basically, it's difficult to check testosterone levels in women because the lab testing is validated for men, not really validated for female levels. So it makes it hard because we're kind of doing this test that's really been validated in male bodies and their testosterone levels are different and our testosterone levels are a lot lower than that. So it's not always very valid when you look at these tests. But
Right. And I tell my patients, if I'm checking a testosterone, I'm checking to make sure there's not too much. Because I know if there's too much, it's going to read on the test. I also know that if there's the right amount, it may not read on this test.
I know.
It may come back 0. That doesn't mean there's no testosterone. It just means there's not too much and it's not reached the validated range for this blood test.
Which is really hard because people are like, I swear my testosterone level is low.
Yeah.
I'm like, well, we just don't have very good testing for that. We don't have very good validated ranges for women. And it's kind of a mess. So testosterone's a little bit limited. So I typically will check it in settings of somebody is having signs of too much androgens.
Yeah.
So I want to see, do they have an elevated testosterone level? And I will check it in somebody who is going to start testosterone therapy
Right.
for low libido because I want to get a baseline and then I want to be able to make sure that their level doesn't go too high while they're on the testosterone therapy.
Right. And I check it regularly while they're on the therapy.
Yep, exactly. While you're on testosterone therapy, which is interesting, right? So while they're on the testosterone therapy, it's one of our menopausal hormone therapies where we actually have to continue to check the level to make sure that it stays within the normal range
Right.
versus we'll talk about in a little bit, like estrogen, we don't necessarily do that, right?
And the
So,
reason is because when we're doing testosterone therapy for women in the United States, we don't have a women's dosed FDA available product.
right.
So even if we're doing the safest possible pathway for that, which is to use the male dosed product at 1/10 the dose, women are having to work with a product that's not at a set dose for them. That's why I check regularly while they're using that, because there can be variation in how much they get every day. And like maybe they're using a little bit too much because it's not as controlled. When you put on an estrogen patch, I know exactly how much you're getting.
Yep.
When you're using this male product on your skin, you're getting somewhere in a range, but I don't know exactly how much you're getting every day. And that's why we're checking. It's when we don't know exactly what you're going to get.
We need to know. And the other thing too is when testosterone levels get too high, they can have irreversible
Yes.
side effects. And we really want to make sure that we intervene before we get to that point. So
Yeah, exactly. That's when we would do that test.
that kind of leads us into like, how often should you check your labs? Because I get this all the time, right? Okay, I'm on estrogen. And they've come from a clinic where they checked their labs all the time and then made doses adjustments. So what do you say to that?
I say never, unless there's a reason to suspect you're not absorbing it.
Yep.
That's basically it.
Yep.
You know, our dose adjustments in menopausal hormone therapy are meant to solve symptoms. So if you are on a dose and you feel fine, I don't really care what your level is because you feel fine. And that's the goal. And if you don't feel fine, I want you to come back and we're going to change your dose. And I don't need a level to tell me that either.
Right.
I think sometimes there's a narrative out there that you have to be at a certain level to protect your heart or your bones.
Mm-hmm.
We have no evidence of that. So, in fact, we have studies. There was a product on the market. It's not even available anymore. What was it called? Menostar?
Yes.
Tiny little patch. So, a patch that's half the dose of the lowest available patch now. So, it was a 0.014 patch.
14 micrograms.
Yeah. 14 micrograms of estradiol. It's like a homeopathic dose.
Yes, you're just getting like a whiff of the vapors.
But they showed that it protected bone.
Yeah.
So any patch I put you on is more than double that. And it's going to protect your bones.
Yeah.
And with cardiovascular protection, we don't know a dose for that. You know, that's not how it's been studied. So all of that data is observational of, you know, outcomes over long periods of time in women who've taken hormones. It's not correlated to any particular dose. So anyone who's telling you you must be at X level to protect your heart is not reading the literature.
No. Well, I just did a whole deep dive into this last night because I was like, all right, am I crazy? Did I miss something? Am I supposed to have something? And I was like, I could find nothing. And the levels that they were looking at, some of them for bone, were very low estrogen levels for bone
Right. You
protection.
don't need much.
Yeah, it's interesting. So I would love to actually have a conversation with somebody who does do this and say, okay, what are your resources? Like, what are we
Tell
doing?
me where you're getting this.
Yeah. Because if there is, like, if it does come out and there are some target ranges, like, we should know that. But as of now, we do not have the data on that. It hasn't been studied in that capacity. We do not have standard guidelines. We don't need to be chasing a number. It's really about controlling your symptoms, and you're going to get the benefit for your bones and your heart. The dose that you're on is just about controlling symptoms and quality of life.
I think it's important to remind people that between the 0.025 patch and the 0.1 patch, so the 25 microgram and the 100 microgram patch, there is actually very little difference. These are all changes within a small range.
Yeah, teeny amounts.
Yeah,
Micrograms are teeny.
micrograms are very small. We're not adding a lot of hormone when we go up. Like I have a lot of patients who get really worried when I say we're going to go to the 0.1 patch. I'm like, it's still a very small dose. It's still probably about 10-fold less potent than any birth control you could be on.
Right. Yeah, it's very tiny.
Yeah. So we're working within a relatively tight range. And, you know, sometimes it's just about finding your secret sauce. And that may change over time.
Yep.
But it's all about you and your symptoms. Like, I'm titrating to your symptoms. I know I'm protecting your bones. I know I'm doing whatever I can for your heart. I know, what benefits you're going to get from being on the estrogen, irregardless of the dosing.
Yep, exactly.
And then we promised a discussion of how to check hormones. Should you do it in the blood? Should you do it in the urine? Should you do it in the saliva?
Lots of saliva testing is out there. A lot of urine testing, like you said, frozen and this and that and freeze dried, and I don't even know what all. So the only validated testing that's out there is in the blood.
Yeah.
So for us, that's the way to go. The saliva testing and the urine testing and all of that, you probably had to pay out of pocket if you did it. It's because it's not validated. So insurance companies aren't going to pay for something that hasn't been validated.
Right.
Blood testing's been around for a long time. We know that those labs are accurate. So what do we mean by validated? We mean it's giving us an accurate portrayal of what's actually happening in your blood.
Yeah. So they actually have to become a validated test, they actually have to do studies where they repeat the test over and over again on similar samples and prove that it comes back with the same result each time. And fundamentally, the saliva and urine tests don't do that, but also can't do that.
They're just not designed for that. So that's not really what.
Right.
So don't waste your money. Save your money for the hyaluronic acid and the vitamin C that we talked about in the face care episode.
Put that on your skin instead.
Yeah, put that on your skin. Take the money for that instead.
Yeah.
Otherwise, forget about doing urine and saliva testing. The exception is the over-the-counter. I mean, there are some urine tests that have been validated. So the over-the-counter ovulation predictor kits can sometimes be helpful. Those are valid. Pregnancy tests, those are valid.
That's also a hormone test. We're testing the human chorionic gonadotropin. Sorry.
So
how did I get all the long words today?
You got all the long words today. I'm sorry.
It's okay.
My perimenopausal brain can't do it. So
no, that's okay.
So that's like our general take-home message on lab testing.
Yeah. And I think, none of this is to dismiss people who are concerned about their health, right?
Oh, absolutely.
And I've had a lot of conversations with people who are like, I just don't understand how you can do this without data. And I'm like, I do have data. It's just different data than you're used to dealing with. It's not a number data, but quality of life and how you feel are very valid and accurate measures.
Yes, totally
And
agree.
I think sometimes we get lost in this thought that if you don't have a number to put to it, you can't possibly be making a good decision.
Right.
And I would argue, like, there's no number you could put to some of these things I'm asking you, right?
Yeah.
I need to know how you feel. And, I really do want to know the answer to that question.
I mean, this is the art of medicine. Some of it is very numbers driven. It's very scientific.
Absolutely.
It's numbers driven.
With your thyroid, I want a number.
We need a number. Thyroid, we've got a range. We need a number.
Yeah.
Yep, absolutely. Testosterone, we need to make sure it doesn't go too high. I need that data. Yeah. Like, you might tell me you feel great on your testosterone, but if I check a level and it's 900, not great.
I got a 900 once.
I love that for you. That's so fun.
So the upper limit of normal for a female is 50, by the way, guys. And so when I said I got a 900, yeah, that's bad.
That's bad. That's not good. So you need both. This is not an algorithm. You can't just like plug it in and then say, oh, your estrogen's this. I need to go up on that and go down on this and da da da. It just doesn't work that way.
I know it seems to some folks to be more scientific that way, but in fact, that's not following the science.
Right.
I hope this was helpful for folks. I know lab testing comes up over and over again. We see a lot of it in social media, in the media. It gets talked about over and over again. And we just wanted to give you some information to sort of help you sort through the weeds.
And figure out what should I be expecting when I go and see my physician. And what are some things that I might want to request if they're not brought up,
Right.
Thinking about thyroid testing, et cetera, et cetera. Well, everybody, we hope this was helpful.
And remember, you're not crazy. This is really happening.